Now we are going to discuss a very interesting area. It's quite a common, terrifying disease, even though it can be treated in a very simple way. So today we are going to deal with Bells Palsy. Let's study a case scenario. We are now going to deal with the history of a 32-year-old nurse who came to my OP, who developed an acute onset of deviation of angle of mouth to the right, with drooling of fluid from the left angle of mouth and also watering from the left eye. It was preceded a couple of days before by an aching pain behind the left ear. There was no ear discharge, no other neurological complaints, and on examination, she had a left element facial palsy. She had impaired wrinkling of the forehead on the left side, inability to close the eye on the left side, the nasolabial fold on the left side was absent and could not blow her cheek, and there was paralysis of the left half of the face, and the left angle of mouth was having a drooling of saliva, and when she smiled, the whole mouth went to the right side. There was a deviation of angle of mouth to the right side. So when a young person develops such a thing, naturally she will be very much stressed, she will feel very sad, so she will be concerned and anxious about her problem, and we started our treatment. So how do you treat this issue? So she has to be treated with acyclovir and steroids. Why the acyclovir? Why the steroids? We will come to it soon. And the artificial tears were applied to that left eye to prevent exposure keratitis. Advice was given to pad the left eye at night during sleep, and facial physiotherapy was also started. Recovery over the next 3 months, the person recovered from her neurological deficit, and now we are going to learn how this disease happens. So for that, we need to have a clear understanding about the 7th cranial nerve. The 7th cranial nerve is a very famous cranial nerve. It is the facial nerve. It is important for all the facial expressions. It's a very mixed nerve. The main role is in supplying muscles of facial expression. It supplies the smallest muscle of the body called as the stapedius. Do you remember what is stapedius? Stapedius is a small muscle inside the ear which dampens the auditory impulses. So large sounds if you are hearing, then the stapedius muscle will contract and will produce a auditory impedance. So it will reduce the auditory trauma. Similarly, the facial nerve is also supplying the taste in the anterior 2/3 of tongue through the chorda tympani branch. It also supplies lacrimal gland. So a wide variety of things it is supplying. It is supplying the muscle in the ear. It supplies the facial expressions. It supplies the taste. It supplies for the eye, for lacrimation. So it has a very wide variety of function. So the nucleus of the facial nerve. So every cranial nerve has a nucleus. So the nucleus is inside the PONS. The brainstem has 3 parts. The topmost is midbrain, then a big one PONS, then the medulla. So inside the PONS you have the facial nerve nucleus. It will wind around the abducen nerve, through the abducen nerve, because if there is a nucleus inside the PONS like this, and then it winds around the abducen nerve. Here you have the abducen. So inside the PONS, the 6 and 7 are very nearby, and the facial nerve will wind around the abducen and come out of the PONS. It comes out like this. So because of this winding, there is the 4th ventricle is here. There is a small bulge which happens in the 4th ventricle. So that is called as the facial colliculus. So the 7th nerve will wind around the abducen nerve and come out. So once it is outside the PONS, it is first in the subarachnoid space. What does it contain? It contains CSF. So through the CSF, the facial nerve will have to now reach a small hole in the petrous temporal bone, which is called as the internal acoustic meatus. So the further course of the facial nerve, it reaches the internal acoustic meatus along with the 8th nerve. So in the internal acoustic meatus, you have the 8th nerve. So you have the petrous temporal bone like this and internal acoustic meatus. 2 nerves are going into it. So one is the 7th nerve and another one is the 8th nerve. So it reaches the internal acoustic meatus. It goes through the petrous temporal bone in close proximity to the middle ear, and then it comes out through a small foramen behind the ear called as the stylomastoid foramen and comes out. And then after that it goes through the parotid gland, and then it gives different branches to the face. So that is the course of the facial nerve. And meanwhile, there are some different branches which are supplied. There is a stapedius branch to the stapedius muscle, a chorda tympani branch which is supplying the stays from the anterior two-third of tongue and also carries the fibers to submandibular nerve. One point to remember is, even though the facial nerve is going through the parotid, it does not supply the parotid. Instead, it is supplying the submandibular gland. So, lacrimal gland is supplied, the submandibular gland is supplied, but not the parotid gland. Now, we will see which are the branches in the face. You can see the different, after the parotid, it divides into different branches. That is called pes anserinus. That is that branching pattern. So, you can see the different branches which are going through this. The first branch which goes up like this is called as the temporal branch. You have the temporal branch here. Then you have the zygomatic branch here. Then this is the buccal branch. You have the upper buccal here, the lower buccal here. Then this is the marginal mandibular branch. And here is the cervical branch. All these nerves are motor nerves which supply the muscles of facial expression. So, let us see which are the common muscles which we test in this. One is the frontal belly of occipital front. We use it like this, wrinkling of forehead, and you look for the symmetry of the wrinkles. That is called the frontal belly of occipital frontalis, for wrinkling of forehead. Then for tight eye closure, you have the orbicularis oculi. Then you have, for showing the teeth, you have the zygomaticus major, minor and risorius. Then for smiling you have to lift up the angle of mouth like this, no? So that is called levator anguli oris. Then for sadness, it has to come down like this. So that is called depressor anguli oris. So different such muscles are all supplied by this facial nerve. Then there are small other muscles again. Suppose you want to frown at a person like this, it is called corrugator supercilii. For tight lip closure and puckering of mouth, something to keep like this, puckering of mouth. Then it is orbicularis oris. For pouting the lips, you have orbicularis oris again. For sucking movements, if you want to make your cheek go like this inside, then you have the buccinator muscle. And for everting the lower lips to make this part very tense, it is called as platysma. So different sorts of facial expressions are made out by the help of the facial nerve. So what are the symptoms of facial palsy? One of the most important symptoms which is brought by the patient is that is a deviation of angle of mouth. They come, doctor, my angle of mouth is deviated to one side. That's one of the earliest symptoms. And because of the angle of mouth deviation, they develop dysarthria. So because of the angle of mouth deviation and weakness of one side, through the weak side there will be drooling of saliva and fluids through the corner of mouth. Then because of weakness of the orbicularis oculi, there can be inability to close the eye. So you can look for these signs like impaired wrinkling of forehead, asymmetrical blink. When the patient comes and sits near you and he starts to blink, he will have blinking only in one eye. The palpebral fissure will be wider on the affected side. For example, if the patient is having a left element facial palsy, this orbicularis is weak. Orbicularis is a muscle like this, so it will be weak. So if it is weak, this eye will be bigger in size. So a larger eye on the side of lesion. And then there will be an inability to close the eye tightly. And the sclera can be exposed. And there is a prominent uprolling of the eyeball. Because the eye is open. So whenever the person is asked to close the eye will be well seen. The sclera can be well seen. And there will be a prominent uprolling of the eyeball, which is called as the Bells phenomenon. Then there will be a loss of the nasolabial fold. There can be a deviation of angle of mouth while he is asked to show the teeth. Leaking of air can be there through the weak corner of mouth. So what are the levels of lesion in an element facial palsy? There are different levels because we already learnt. The facial nerve starts from the PONS, goes through the CSF, CP angle, then internal acoustic meatus, through the middle ear. It has to come out of the stylomastoid foramen and parotid and it supplies. So at every point, different sort of diseases can catch hold of this nerve and can be affected. So PONS, at the level of PONS, many diseases can affect it. In the subarachnoid space, many diseases can affect it. At the Cerebello Pontine angle, there are some diseases. Inside the temporal bone, then at the stylomastoid foramen, inside the parotid gland, or it can be affected in the branches, or sometimes the disease can be multifocal. So if there is a lesion at the level of PONS, let us see how to differentiate, because there should be some point to differentiate the disease at different levels. So always look for the company it keeps. For example, inside the PONS, you have the nucleus and the fiber which is coming out from that. So, what are the nearby structures inside the PONS? We have three structures. One is sixth nerve, because we already told the sixth nerve is actually, wow, there is a sixth nerve nucleus here, the seventh nerve nucleus here. The seventh will have to come around the sixth nerve and go out like this. And when going out there, the pyramidal tract is also nearby situated. So what happens here? Pyramidal tract is here. So the sixth nerve, the seventh nerve may be associated with sixth nerve. 7 and 6 may be together affected. Similarly, the pyramidal tract may be affected. So these combinations are possible. So 6 plus 7, if you see, it is in the PONS. Similarly, 7th palsy with a contralateral hemiplegia, again it is in the PONS. It's a crossed hemiplegia. Then you can have, there is another tract called as the medial longitudinal fasciculus. So if the medial longitudinal fasciculus is affected, the 7th nerve can be associated with internuclear ophthalmoplegia. So if you get 6 and 7 together, 7 and pyramidal tract, 7 and MLF, then all these combinations tell you that the problem is in the PONS. Now after the PONS, it enters into the subarachnoid space. So subarachnoid space, what is there? The CSF is there. What are the diseases which can affect the CSF? One is subarachnoid hemorrhage and second is meningitis. So meningitis and subarachnoid hemorrhage both will have neck stiffness. So if a person is having neck stiffness with an element facial palsy, the problem is in the subarachnoid space. So meningitis, especially the tuberculous meningitis, the fungal meningitis, granulomatous meningitis. So these are some of the meningitis which have a higher propensity to affect the facial nerve. The metastasis in the meninges, meningioma can occur in the CSF. Berry aneurysms. Berry aneurysm is that from which the subarachnoid hemorrhage occurs. So berry aneurysm, subarachnoid hemorrhage, meningitis, all these can pick this 7th nerve at the level of meninges. Now, just after that, the person is, the facial nerve is at the CP angle, Cerebello Pontine angle. There are two diseases in the Cerebello Pontine angle which are critically important, very famous, acoustic schwannoma, and a close differential diagnosis would be a meningioma. So meningioma and acoustic schwannoma can pick the facial nerve, producing an element facial palsy at the Cerebello Pontine angle. So how do you find out whether it is a Cerebello Pontine angle? As the word meaning, cerebello is there, no? So cerebellar ataxia will be there along with deafness, because 8th is also very near. So deafness, ataxia and 7th nerve palsy, that combo will tell you that this problem is at the Cerebello Pontine angle. Now what is this Bells palsy? That is our topic proper. It is the most common cause of element facial palsy. It's an acute unilateral element facial palsy. It's a self-limiting disease. Typically it is a monophasic illness. Herpes simplex virus is considered to be the etiology. So initially it was called as an idiopathic facial palsy, but later on it has been found that the herpes simplex virus was isolated from those nerves and perineural tissue. So herpes simplex virus infection is the cause for Bell's. That is why in the initial case we treated that person with acyclovir, because herpes simplex virus, the drug of choice is acyclovir. So it starts as a pain behind the mastoid in 60% patients. Other cranial nerves are unaffected, just element facial palsy alone. No long track signs are there. And if you take an MRI in a Bell's palsy, what do you see? There is a canal called as the internal auditory canal. Inside that canal, the MRI often reveals enhancement of the facial nerve, especially at the geniculate ganglion, because the facial nerve, as it goes through the internal acoustic meatus, there is a small ganglion. That the first bend, the facial nerve goes in like this and bends like this. At the bend, you have a ganglion called as the geniculate ganglion. Geniculate ganglion. It is from the geniculate ganglion, it is inside this geniculate ganglion, this herpes simplex virus will proliferate, which leads to an element facial palsy known as Bell's palsy. Taste can be affected in 30 to 50, because it is after the genu, the chorda tympani is coming, then the nerve to stapedius is coming. So the taste can be affected. Hyperacusis due to involvement of stapedius can be there. And what is the prognosis? What happens to these people who develop this viral infection? 85% will have a good spontaneous recovery in 3 to 4 weeks. Some residual weakness can be there in 10 to 12% of people. After some people with chronicity, suppose this 10 to 12% of persons who don't recover from this Bells palsy are followed up for a chronic Bells palsy, that affected side will show some contractures. So there can sometimes be a paradoxical deepening of the nasolabial. So chronic element facial, there can be a paradoxical deepening of the nasolabial fold and sometimes a narrowed palpebral fissure. Acute Bells palsy, there is a wider palpebral fissure, loss of nasolabial fold. But in a chronic case, the nasolabial fold may become more prominent and the eye may become smaller because of contracture of the muscles. And in some chronic cases, aberrant regeneration of this lacrimal gland can occur, which lead to excessive tear secretion during facial muscle contraction and chewing, swallowing, etc. They are known as crocodile tears. So how do you treat a case of Bells palsy? You start them on acyclovir, 800 mg 5 times a day for 1 week. And also you give steroids for around 2 weeks at a dose of 1 mg per kilogram per day of prednisolone. So prednisolone and acyclovir, and you have to give supportive care because specific care is acyclovir and prednisolone, but supportive care is you have to pad the eye and close the eye at night. Artificial tears like hydroxymethylcellulose eye drops should be put into the eye every 4 hours to prevent exposure keratitis and dry eyes. So these eye drops, hydroxymethylcellulose should be given. Facial physiotherapy and electrical stimulation as part of neurorehabilitation. So specific treatment is acyclovir and steroids, and you have to give this supportive care also. What are the conditions which produce a recurrent element facial palsy? As it could be a part of Lyme's disease. Lyme's disease is an infection produced by an organism called as Borrelia burgdorferi. So Lyme's disease can produce recurrent element facial palsy and also sarcoidosis, which is a non-caseating granulomatous disease. Then Ramsay Hunt syndrome. We already told facial nerve has a genu, it has the geniculate ganglion. Geniculate ganglion, if it is affected by herpes simplex, it leads to Bells palsy. If it is herpes zoster, it leads to Ramsay Hunt syndrome. So herpes zoster affecting the geniculate ganglion is Ramsay Hunt. It's also an acute element facial palsy. What is the basic difference? What point helps you to differentiate it from Bells palsy? Always look into the internal acoustic meatus. Small vesicles in the external auditory meatus. It is not internal acoustic meatus, the external auditory meatus. If you can find small vesicles, that will help to make a diagnosis. So always make a point to look into the ear and see those look for those vesicles so that you can make a positive diagnosis of Ramsay Hunt syndrome. The facial weakness is often more severe and spontaneous recovery is less common in Ramsay Hunt. So Ramsay Hunt is more a dangerous disease than Bells. So the facial weakness is more severe and spontaneous recovery is less common. And inside the temporal bone, now so that's over. Then inside the temporal bone, what are the diseases which can affect the facial nerve, producing an element facial palsy? A complicated ASOM, CSOM, skull bone neoplasms, fracture of the petrous temporal bone, an intratemporal facial nerve schwannoma. So these are all possible, especially the fractures, metastasis, infections. Another named syndrome is called Gradenigo Syndrome, which is inflammation of the petrous apex. How does petrous bone apex gets inflamed? It is often a complication of a suppurative otitis media, ASOM or CSOM. So this is one of the complications where facial nerve palsy can be there along with fifth nerve and sixth nerve, 5, 6 and 7, along with pain in the ear. That is called Gradenigo Syndrome. What are the diseases which can affect the nerve in the parotid gland? Because after the stylomastoid foramen, it has to go into the parotid gland. Parotid gland tumors, surgery of the parotid, infiltration of the facial branch by the skin neoplasms. Skin neoplasms here can infiltrate the facial nerve. Hansen's disease, Lyme's disease, sarcoidosis, they usually affect the distal branches in the parotid or outside the parotid. So the distal branches are affected by these disorders. Then lastly, we will come to one rare syndrome where you have an element facial palsy called as the Melkersson Rosenthal syndrome. It's a rare granulomatous disease with this sort of a triad. Facial nerve palsy, LMN will be there, along with facial edema and a fissured tongue. So if you get this combination, you can make a positive diagnosis of a rare syndrome called as the Melkersson Rosenthal syndrome. Now we will go to the MCQs. MCQ number 1. Simultaneous bilateral element facial palsy is commonly seen with. When do you get a bilateral element facial palsy? That's the question. Bells palsy, it is usually unilateral. Gradenigo syndrome, it is usually one ear which is affected, so it's unilateral. Guillain-Barré syndrome is a symmetric polyneuropathy. So symmetric neuropathy is Guillain-Barré syndrome. So Guillain-Barré syndrome can definitely produce bilateral element facial palsy. Diabetes is often a cause for element facial palsy, but it is often unilateral. So the answer to this question is Guillain-Barré syndrome. We go to the second question. Cause of facial muscle weakness are all except. Let us see each one. Myasthenia gravis. Myasthenia gravis, the facial muscles also can become weak. Initially the eye muscles can become weak. Later on the bulbar muscles can become weak. And later the facial muscles also can be weak in myasthenia. So myasthenia can produce facial weakness. Then another muscle disease is facioscapulohumeral dystrophy. So that is a peculiar type of muscle disease where the facial muscles are severely affected. So that also produces facial palsy. Hansen's disease, we just only heard. Hansen's disease can produce an element facial palsy. So all the three can produce facial muscle weakness. But the last one, transverse myelitis. Transverse myelitis is a disease which affects the spinal cord. So spinal cord is affected in transverse myelitis. So spinal cord disease doesn't produce a facial palsy. So transverse myelitis is the answer to this question. We go to the last question. Bilateral UMN facial palsy. Initially the Guillain-Barré question was bilateral LMN facial. Here bilateral UMN facial palsy is seen in which condition? Is it in pseudobulbar palsy, lateral medullary syndrome, medial medullary syndrome, Millard-Gubler? So what are these? What is this Millard-Gubler syndrome? Millard-Gubler syndrome is a problem inside the PONS where 6th nerve is affected, the 7th nerve is affected and the hemiplegia occurs. So that produces, it's a unilateral disease. So it's not bi. So it's an LMN facial palsy. So this is an LMN facial. Lateral medullary syndrome and medial medullary syndrome are in the medulla. So that doesn't produce facial palsy. So these are also not there. So what is this condition? The pseudobulbar palsy. This is the bilateral UMN phase. Pseudobulbar palsy means the person is having disease above the level of brainstem. Brainstem above the disease. So pseudobulbar palsy is often seen in disease where there is a bilateral disease above the level of brainstem. So that would be the condition where it can produce a bilateral UMN facial palsy. So that's all. Thank you.
Docemy.